Hello, Hyperoxaluria community. My name is Kim Hollander. I am the Executive Director of the Oxalosis and Hyperoxaluria Foundation, better known as OHF. I can't believe this day is finally here. I'd like to welcome you to the OHF Interactive Patient Workshop, where we hope you'll gain valuable insights and also help us better understand your particular access challenges. A special welcome to our industry sponsors who help make Hyperoxaluria Week, as well as our virtual patient meetup, possible. We couldn't do this without you. Thanks to Alnylam, Dicerna, a Novo Nordisk company, Chinook Therapeutics, and Precision Biosciences for their incredible support. I'm joined today by my co-host, Dr. John Liskey from the Mayo Clinic. Dr. Liskey is the leading expert in the field of hyperoxaluria, and it's my honor to have him here with us in the studio. By the way, John, I see you're wearing hyperoxaluria blue. I'm so excited. Way to represent. So Dr. Liskey, tell us why access in your profession is so important to our community.
Thanks, Kim. Well, as you know, both primary and enteric hyperoxaluria are very rare diseases, so that any given patient, their physician may not have a lot of experience with them. So it's really our job to help get them the expertise they need and give them access to the latest diagnosis as well as treatment options.
Yeah, that's fantastic. Thank you so much, Dr. Liskey. And most importantly, I want to thank you, the members of our community. This meeting is about you and for you. Hyperoxaluria Awareness Week is our chance as a global community to join together and raise awareness with the goal of generating change for people everywhere living with hyperoxaluria, their families, and caregivers. This week, we celebrate how far we've come. The pharmaceutical industry has been very interested in hyperoxaluria in the past several years, with numerous research studies and clinical trials already underway or in the planning process. It's the dawning of a new age for everyone affected by hyperoxaluria. In the fall of 2020, OHF received the most incredible news. While the majority of us and the world was on lockdown, that Oxlumo, lumasiran, the first drug to treat patients living with PH1, was approved in Europe and the US, which is an incredible milestone in OHF history. Even last week, we learned that a second drug called nedasiran, also for PH1, is under review for approval at the FDA. Extremely promising. Our work, however, must continue since we have to ensure access to these life-saving drugs for all families around the world. We need to remain steadfast as a community and work together to develop treatments for all types of PH, as well as enteric hyperoxaluria. In order to institute change for our worldwide community, it means all of us, including you, must take action. OHF relies on you to help make the future a brighter one, so that ultimately we can have access for all. This is your right, your fight, and your future. Well, we have a lot to learn from all of you today. You'll have a chance to respond to a number of polling questions online and also ask questions to our panelists along the way. I know watching this on a screen cannot replace an in-person meeting, but I promise OHF will be back on the road, hosting both professional and patient meetings in 2023. So now, let's get started with some polling. Go ahead and open a browser, either on your computer or your mobile device. You can also access this on our web page. Go to pollev.com/HAW 2022. We ask that you respond for one individual in your family. Or if you have multiple devices, please have each individual member participate themselves. Kids are welcome. Let's start with the first question. Okay, easy one. Where do you live? A, U.S. in the Northeast, B, Mid-Atlantic, C, Midwest, D, South, E, U.S. Mountain, F, in the West, G, Canada, H, Central or South America, I, Europe or UK, J, Asia, K, Africa, L, Australia or New Zealand, I know it's late, and M, any other place. Wow, the results are rolling in, Dr. Liskey.
Yeah, a lot from the Midwest and the Northeast so far. At least one or two from Europe.
Looking good. So it looks like primarily, we're still changing. Okay. Wow, it looks like a great representation from the Northeast. So that's where I'm from. I live in New York. Dr. Liskey is from Mayo Clinic in Rochester, Minnesota. So this is really exciting. Great presentation. And we have a lot of people from Europe and the UK. And it looks like our friends from Canada just joined us.
Yeah.
Pretty amazing. Okay, so let's move to the next question. Do you or someone you care for have hyperoxaluria? We'll give everyone a few minutes to respond. Wow, we're really seeing a lot of people that are caregivers.
Yep, and some patients too.
Yeah, it seems like it's leaning about 67% of the people on the call today is caring for someone with hyperoxaluria disease. Oh, it's even changing again. Close to 86%. Wow. So it's about an 80-20 split. Fantastic. Well, welcome everyone. Next question. What type of primary hyperoxaluria have you or a loved one been diagnosed with? Again, what type of primary hyperoxaluria have you or a loved one been diagnosed with? We'll give everyone a few minutes to respond here.
So far, PH1.
PH1 is really in the forefront. Any twos or threes? Here we go. We knew you were hiding out there.
So a 2 or so.
Yeah, so we're seeing about a 90-10 split between PH1 and PH2. I'm sure through today's presentation, we'll have patients represented in both the unknown and PH3 categories. I know people are waking up on the West Coast, and our Europeans are joining us in the evening, so I'm sure this will update accordingly.
I'm sure people are figuring out this polling system too.
That's correct. Okay, so we do look like we have patients from PH1, PH2, and PH3
Some PH3,
represented.
wow.
Yeah.
Late surge.
Late surge. Here we go. Okay, next question. Have you or someone you care for received a diagnosis of enteric hyperoxaluria? We'll see if we have any patients from the enteric community.
Oh, we do.
Wow.
Both patients and caregivers.
It looks like it's a 50-50 split, which is really great. Welcome, everyone. All right, so moving right along to the last and final question for this section. What is your or the affected individual's age? Younger than 12, 12 to 17, 18 to 29, 30 to 39, 40 to 49, 50 to 59, or 60 or older? And we'll give everyone a few minutes. We know some of the people are waking up in the Midwest and on the West Coast. It is Saturday, and we're a little slow to get started. Get your cup of coffee, and here we go.
So far younger than 12. It's a big chunk.
Yeah, interesting. Great. We have a lot of different age groups represented. So we're seeing about 70% look like there's some caregivers. And then we have a lot of young people, 18 to 29, and people in their 50s as well joining.
Yeah.
Okay. Well, Please keep on your polling. We will be doing polling throughout the program. So right now, I would like to introduce you to our first biotech update. And please welcome me to say hi to Dr. Vaishnav from the president of Alnylam. So thank you so much, and we'll turn it over to Dr. Vaishnav.
Hi, my name is Akshay Vaishnav, and I'm the president of Alnylam Pharmaceuticals. We're proud to be here today with you and the OHF to celebrate Hyperoxaluria Awareness Week. We're grateful to the OHF for their leadership and many years of collaboration, as well as this opportunity to share a little bit about Alnylam and Oxlumo, otherwise known as lumasiran, with you here today. Our company Alnylam was founded in 2002 by a team of distinguished life science leaders who guided us in the translation of RNA interference, also known as RNAi, from a Nobel Prize-winning discovery to an entirely new class of medicines that disrupt disease by silencing disease-causing genes. Fast forward to today, and we're a company with offices around the world and with 5 marketed products serving patients. After conducting the largest clinical trial in PH1, Oxlumo was approved by the FDA in November of 2020. Then just last month, in October 22, Oxlumo received an expanded label treatment of PH1 to lower oxalate in urine and blood in patients with PH1. This expansion was based on a clinical study that included patients with advanced PH1, including those with chronic kidney disease or kidney failure, as well as patients on hemodialysis. Oxlumo works in the liver to reduce the amount of oxalate being produced. Because Oxlumo reduces oxalate production, less of it is circulating in the body. The most common side effect of Oxlumo in clinical studies was injection site reaction. Additional safety information will be shared throughout this video. To tell you more about Oxlumo, we're delighted to have Dr. Hilary Stone, a pediatric nephrologist at Cincinnati Children's Hospital, as well as a patient and a caregiver, who will share her information and experience. Thank you for having us today. We're humbled and excited to be joining the OHF and you all during Hyperoxaluria Awareness Week.
What is Oxlumo, or lumasiran? Oxlumo is a prescription medicine for the treatment of primary hyperoxaluria type 1 or PH1 to lower oxalate in urine and blood in children and adults. Important safety information. The most common side effect of Oxlumo is injection site reaction, such as redness, swelling, pain, bruising, itching, and discoloration at the site of injection. These are not all the possible side effects of Oxlumo. Talk to your doctor about side effects that you experience. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088. Please see important safety information throughout this video and full prescribing information at www.oxlumo.com or by scanning the QR code on this slide.
Our conversations have really shifted, and so now we talk to patients about this medication that can actually treat PH1, and we've actually been able to get urinary oxalate levels into the normal range.
I was first diagnosed with PH1 when I was around the age of 8. My parents were told that I would not live past my teenage years. I began receiving lumasiran in a clinical trial. Eventually, it was approved by the FDA as Oxlumo. When I go and meet my doctor now, I am excited. It's progress, and it's good news.
When Owen was first diagnosed, there were limited treatment options for patients with PH1. It was heartbreaking as a parent to see that this was where the journey was going to lead for us. Having been on Oxlumo for the past 2 years has allowed his oxalate levels to normalize.
I wanted to be a doctor because I wanted to be able to make a difference in someone's life. In PH1, I really feel like I can make a difference in their life.
Important safety information. Oxlumo or lumasiran has not been studied in pregnant or breastfeeding women. Talk to your doctor about the risk of taking Oxlumo if you are pregnant, plan to become pregnant, are breastfeeding, or plan to breastfeed. For additional information on Oxlumo, please scan the QR code for the full prescribing information. To learn more about Oxlumo, talk to your doctor and visit oxlumo.com. Scan the QR code for the full prescribing information.
Wow, that was a really great presentation, Dr. Liskey.
Yeah, it's very exciting times in PH. We have new treatments under development and already approved even.
Yeah, it's wonderful, wonderful to see, and thank you for the patients sharing their story. It's incredible. So next up is our final biotech update for the day. And we would like to welcome John from Dicerna, a Novo Nordisk company. John, I'll let you take it away.
Thank you, Kim, and thank you to the OHF for this opportunity to be here. We're very, very excited to be here and provide an update on Dicerna and nedosiran, our molecule that is now submitted and under review for patients with PH1. I'd like to give you a little bit of background on Novo Nordisk and what happened with Dicerna. We were actually acquired by Novo Nordisk at the end of last year, and we're now part of this larger organization that has a very, very strong commitment to patients in general. They have presence in over 100 countries. They have many, many marketed products, including several products in the rare disease space. So they have a strong commitment and legacy in rare disease with products for growth hormone, for example, hemophilia. They're very, very interested in also nephrology, and nedosiran will hopefully be the first introduction to patients there. So by way of update on nedosiran, I just wanted to share a quick update there. We did file. So nedosiran is another RNAi type therapy for patients that have PH1. We are seeking for an indication for patients that are 6 and over with intact renal function. And we're quite excited that this drug now will offer hopefully a choice should the drug come to market and get approved. Not sure if there's an issue with something there. Can you guys hear me okay?
Yeah.
Okay. All right. I was trying to read the facial expressions here in the room. It seemed like maybe you weren't able to hear me. So
Can he see us?
we also most importantly want to thank the patient community because many of you have been involved in our clinical trials, and we want to thank you for your support. We do have a couple of ongoing studies now with nedosiran. We have a pediatric trial in patients that are from birth up to age 12. That will be a separate new indication. And then we also have another program for patients that have impaired renal function, GFR less than 30. I would say the other two important points to consider based on our mechanism of action, we do believe there may be some benefit in PH2 and PH3. And I noticed that that community also needs, of course, a therapy to come to market. And we're very committed there. We have some plans. We will need additional studies to support those indications. Currently, we are filing only for PH1, but we haven't forgotten about you, and we are very much committed to bringing hopefully nedosiran as a therapeutic option for patients that have PH2 and PH3. I think I'll stop there for now. Hopefully, you're able to follow the update here. Sorry for just the verbal update, but I wanted to convey, why we're now Novo Nordisk. You see that name and where we are by way of filing in our commitment to PH2 and PH3. So I'm going to turn it back to Kim at this point.
John, I just want to thank you for that incredible overview. I noticed as you were speaking, we did have one question pop in. So Dr. Liskey?
Yeah, it looks like it's one of our patients from Europe maybe. It says, do you know when we would have nedosiran available to patients in Europe?
That's a great question. So we are looking to file also in Europe in the 23 timeframe. We're targeting mid-year. It's not finalized yet, but we are targeting mid-year for filing. The idea would be to use the same pivotal trial, our so-called FIOX2 trial, and then our long-term extension trial data to seek approval again for for PH1 in patients 6 and over with intact renal function. So that's currently the plan. That's a great question.
No,
Thank
that's
you
good
for that.
news.
Great news. John, we just want to thank you so much, and just to all the patients out there, this is a really exciting time, and we thank you so much for presenting this morning. It was very enlightening. And as drug companies like Novo Nordisk file, it does take a while. So the FDA and the EMA will actually go through a long, tedious approval process, but we'll stay steadfast and keep you posted along the way of any updates. So, really excited to bring you our next session, which is DiagKNOWsis, being in the know. And wonderful presentation by Dr. David Sass, who is a pediatric nephrologist from the Mayo Clinic. So David, take it away.
Thank you so much, Kim and Dr. Liskey. It's my pleasure to be here this morning. Thanks to everyone who's tuning in. I am a pediatric nephrologist at the Mayo Clinic, and we are currently having some wonderful snowfall right now. It's very pretty outside. So we're going to go through these slides related to making the diagnosis of primary hyperoxaluria with a brief introduction as to what it is. I think probably most of the people know what it is, but I just want to make sure we're all on the same page. I also want to apologize in advance for some of the slides are not the way I organized them, and looks like when they were formatted, the formatting was changed. So I apologize. I usually put together a more organized set of slides than this. First case example right here. There are random arrows and boxes around here, but we will do the best we can. All right, so let's talk about what is hyperoxaluria. So the word hyperoxaluria, hyper means too much, oxal means oxalate, and urea means in the urine. So it's an overabundance of oxalate in the urine. And there are a few different ways that we can get there. So one of the entities we talk about is enteric hyperoxaluria. So the word enteric refers to the gut, right, the intestines. So you can absorb too much oxalate through your gut. And so that can happen through either eating too much oxalate, as some people do, and that can lead to hyperoxaluria. Or there are some people who have medical conditions that can lead to increased absorption of oxalate from the diet. So conditions like inflammatory bowel disease or cystic fibrosis, or patients who have bariatric surgery to address obesity, they all absorb oxalate very avidly from the intestine, which leads to enteric hyperoxaluria and too much oxalate in the urine. So then we can also develop hyperoxaluria from primary hyperoxaluria, which is, as you all know, a genetic condition that leads to increased production of oxalate, right, primarily by the liver. So you get this massive oxalate production, which then leads to higher oxalate in the urine. And any of these conditions that lead to higher oxalate in the urine can result in calcium oxalate kidney stones and nephrocalcinosis. So nephrocalcinosis is a term that means it's a slightly different from kidney stones. It's a calcification of the actual tissue in the kidney. Okay, so we covered this, that hyperoxaluria is an overabundance of oxalate in the urine, and that pH is the inherited generic inborn error of metabolism where you have increased production by the liver of oxalate. So that calcification in the kidneys and the stones themselves, all of that leads to decreased kidney function in a significant subset of patients. So when we talk about kidney stones, you know, we're all born with a genetic background that either makes us more likely or less likely to form stones on a given day. When you're born with PH, unfortunately, the genetics have you pinned up to the right side of that figure where you're very likely to form stones, which means you have to work very hard to not form stones. So how do we identify patients with these genetic conditions? How do we identify patients with primary hyperoxaluria? Well, they come to a pediatric nephrologist from a few different angles. The most common way we identify patients with PH is those who present with kidney stones or nephrocalcinosis, less commonly hematuria, which means blood in the urine, or even decreased during our evaluation of a patient with decreased kidney function. And so these patients are usually referred from either a urologist who is in charge of removing stones when they're causing trouble, a primary care physician who's identified any of these above problems, or an ER or urgent care doctor. So they make the referral, they identify the stones and say, this is someone who requires expert evaluation, so they send them to the pediatric nephrologist. We also identify, you can see on the bottom of this slide, we also can identify patients with PH through family history, right? If someone has PH and they have a sibling, we really strongly suggest that we screen the sibling, even if they've been asymptomatic. Sometimes stones don't cause any clinically evident problems, but they still may have significant disease. So we encourage that evaluation of siblings. All right, so then we're going to run through a case here, just as sort of a typical example of how we, stepwise, how we make the diagnosis. So here we have a 14-year-old boy who presents with recurrent kidney stones, meaning he keeps getting stone after stone, and initially found to have bilateral kidney stones. So bilateral means in both kidneys, on both sides, which signifies that it's pretty significant and severe disease. And so he first presented to the emergency department when he was 11. It's followed by a urologist who a number of times has gone in surgically and taken out the stones. And then finally, the parents say, hey, maybe we should try to figure out why this is happening and see if we can stop it from happening. So they refer to a stone expert, usually a pediatric nephrologist, for the evaluation. Then the critical part of the evaluation is this 24-hour urine collection. So the 24-hour urine collection, as you're probably all familiar with, and as the name implies, is where instead of urinating into the toilet for 24 hours, you urinate into a jug, and we get a sample of that and analyze it for a couple of dozen different risk factors related to stones. So if we find in that 24-hour urine that the oxalate is very high, that should trigger concern for primary hyperoxaluria. But it could also be enteric hyperoxaluria. So further testing to delineate is required. So the next step in the evaluation, sometimes we perform just on a random urine sample. We run a test here at Mayo called the Hyperoxaluria panel that can tell us about whether a patient who has hyperoxaluria is likely to have pH type 1, 2, 3, or an enteric type. So this is the how we tease out the results from that hyperoxaluria panel. And I apologize, this is not aligned properly. pH 1 should go with glycolate, and then pH 2 should go with glycerate, and pH 3 should go with that bottom one, the 4-hydroxy-2-oxyglutarate. So this test can give us some clues. It's not a definitive test, no test is 100% definitive, but it gives us some good clues as to what might be causing the patient's hyperoxaluria. If we see none of those elevated, none of the glycolate, glycerate, or 4-HOG, then we say, this might be enteric hyperoxaluria. All right, so once we have these tests, like in our patient with the elevated oxalate and glycerate, that's strongly suggestive of pH 1. So now the final step for confirming the diagnosis is genetic testing. And by the way, you could argue that you could do genetic testing earlier, even just, depending on the results of some of the other testing, particularly the 24-hour urine, that can push you one way or the other and make you think this is more likely to be a genetic cause and go through proceed with the genetic testing. So just a word about genetic testing. So genetic testing can be done either through a commercial lab or a research lab. So the difference is a commercial lab is a lab that is set up to run testing in the American style and to make money, right? So they charge your insurance, and that's fine. That's the way our medical system works. But just so you know, there are also research labs out there that do testing for research purposes in an effort to help gain more knowledge about the different types of mutations and what other things might be contributing. And so research lab testing is often free for the patients, but sometimes, and I say this because we do it, so I know, we are sometimes a bit slower, but that's because we have fewer resources because we're not doing it for profit. But just know that those are the two different ways that you can approach genetic testing. So I just have this slide. This is from our Rare Kidney Stone Consortium here at the Mayo Clinic. So I just want to focus on, this is about delay in diagnosis. So this is showing the 3 types of PH, 1, 2, and 3. And what I want you to look at is the age of presentation. So this is when the patients first presented with their kidney stone problems or whatever other abnormality made them go to the doctor. And the bottom part tells you their age at diagnosis. So you can see there is, roughly an 8-year gap between the onset of presentation and the diagnosis. So 8 years was our sort of typical waiting time for the patients that ended up coming to us. That delay in diagnosis can be significant, especially now that we have a treatment, right? So now that we have some significant improvements in treatment options, it's even more important that we make the diagnosis sooner. So once the diagnosis of PH is confirmed, then the nephrologist and the family get together and talk about a treatment strategy based on the needs of the patients and the severity of the disease. So certainly all patients with PH, as everyone on this call knows, require very aggressive water intake. And we usually start them on a crystal inhibitor like potassium citrate. A subset of patients with PH1 and a particular set of genetic variants may respond to vitamin B6 or pyridoxine. Those are synonyms, they're the same thing. And for those patients, we get them started on vitamin B6 and see how much it brings down their urinary oxalate. And then finally, for those with PH1, the siRNA inhibitors like lumasiran and nedosiran coming soon are effective, and we should consider starting them on those medications. So, and then going forward, you have to carefully monitor the patient's kidney function through blood testing. 24-hour urines are useful to determine the efficacy of your treatment and where you are stone risk-wise. And then, of course, the stone burden, both on imaging, right? So ultrasound or CT scan, are you forming more stones? Are your stones getting bigger? Well, that means we're not being aggressive enough with our treatment. And then, of course, are you passing stones? We want to know if you're having those very painful stone passage episodes. So my take-home points for today are that stone formers, especially, I'm a pediatric nephrologist, of course, so I think particularly about children, especially children, should have a complete evaluation, including a 24-hour urine collection. And then for calcium oxalate stone formers, hyperoxaluria should trigger further evaluation for the source of the hyperoxaluria. Is it enteric or do they have genetic PH? And then genetic testing can confirm the diagnosis and is important to consider. And I really strongly believe that we should be testing first-degree relatives of our patients with PH. All right, so that is just my quick overview of PH and how we arrive at the diagnosis and some of the challenges we have. And I'm not going to list everyone here. You can see the list of names of my colleagues at the Rare Kidney Stone Consortium and elsewhere around the world. So I would be happy to take any questions.
Wow, Dr. Sass, that was an incredible overview, and we apologize the mishap with the reformatting of your slides, but as a professional, you just nailed that presentation, so thank you. I do see that we actually had some questions in, so I'll turn it to Dr. Liskey and
Yeah, thanks, David. I'll pretend I'm excited to hear it's snowing in Minnesota already. So the one question I see in the chat here is, I've already done commercial testing for pH. Is there any advantage to doing research testing?
That's a great question. So the short answer is yes. So the potential advantage for the research testing is that, number one, you're contributing to the field. So by providing your genetic information to the people who are studying it, we're able to, it just improves the amount of detail we have, the amount of patient information we have, and it helps us advance the field. Number two, it may be helpful for you. So, you know, the folks who are doing research-based testing might be taking a really close look at the information. It might be looking at more genes. For instance, you know, in our panel, we look at 144 different genes related to kidney stones, whereas some of the commercial ones may only look at 30. So they're able to make that diagnosis with the commercial testing, but we may be able to dig a little deeper. And then also, those samples can be used in the future too, if there are new studies and where we want to look at things again. So yes, I think there can definitely be an advantage. Even though you may already have the diagnosis, it may be advantageous to you and to the field of pH to go ahead and engage in research-based testing.
Do we have time for one more?
Yeah, let's do one more.
Okay, so looking into the future, what advances do you foresee that will make our ability to identify patients with pH easier?
That's right. So first of all, education. So working with the rest of the nephrology and urology community to help understand what are the warning signs of pH and when should you go forward with an evaluation. That's going to be a big part of it. And we're working with the OHF to come up with some guidelines to help educate people. And then number two, I think accessibility to genetic testing is just going to get easier and cheaper. And that's going to be the key, right? You know, at some point, genetic testing is going to be like ordering, you know, a complete blood count, and we can get results in hours instead of days or weeks. So I think the accessibility of easy genetic testing will be, for sure, helpful in the future.
Makes sense.
Dr. Sass, we just want to thank you so much. It was incredible, and I agree. We hope that we see more accessibility to genetic testing in the future. So now I want to turn it back to the audience. So get your mobile devices and your laptops or whatever, and we're going back to a few polling questions. All right, everyone. So I received genetic testing through, and there's a bunch: Mayo Clinic, Invitae, a clinical trial, D, my doctor, my medical institution, E, F, a liver biopsy, this is how it was done in the past, G, unsure, and H, other. And if you're not sure, just, it's okay, put G. But if you do know how you received your genetic testing, please let us know. So we're seeing a lot of people right now come in through a doctor and Invitae.
In my medical institution. Yep.
This is great. We're really seeing the numbers move. And if anyone did have their testing through Mayo Clinic, now we're starting to see some changes. This is wonderful. So I would say half the participants, Dr. Liskey, it looks like it's from their doctor.
Right, which makes sense. I don't know that the doctor always goes into the details of how they're getting those results.
Yeah, it would be interesting to dive into that a little bit further. Okay, so now let's look at our second question. Moving forward, great. Is your diagnosis enteric hyperoxaluria? How were you diagnosed? 24-hour urine analysis, a stool sample, C, history of kidney stones, D, other, or it does not apply. We'll give everyone a few more seconds to answer this, but it looks like the majority of people it does not apply to. So we do have a lot of participants with primary hyperoxaluria, or a family or a loved one with primary hyperoxaluria on the line. So this sort of
makes sense.
Makes sense. Okay, everyone, keep those mobile devices handy, but we're going to close out that polling session and move right into the next session. So we're looking at your registry, your future, your data matters. And brought to you live from Rochester, Minnesota, also very cold state, and probably snowing in Carly's backyard is Carly Banks. Carly, I'll turn it to you.
Hi guys, thank you. Dr. Sass and I aren't too far from each other, so it is cold and snowy here, quite a stark contrast from Orlando where we were all meeting together and talking about all these important issues last week. So quite a body shock. But I am Carly Banks. I'm a certified study coordinator here at the Mayo Clinic. I have worked with Dr. Liskey and Dr. Sass for about 8 years now. And I'm here today to talk to you about why it's really important for you to join the OHF PH registry. You'll notice throughout my slide deck, you'll see a QR code. Feel free to scan that with your phone. That's going to take you right to the OHF website that will allow you to be able to sign up for the registry. And if you're not sure if you're signed up for the registry, fill the form out because Kim and Julie will work with us and find out if you are. So I just wanted to highlight the PH patient registry. It's for patients who are diagnosed, who are unknown. It helps improve quality of care. It helps accelerate drug trials. Without the PH registry, we would not have seen FDA approval of lumasiran and the application for nedosiran. Those were two drug studies that, relied heavily on the multitudes of data that we've accumulated from this registry. So what is the registry? It was launched in 2003. It's a registry that was the first of its kind. It uses information from your healthcare form and your family history to form a complete picture of the disease. To participate, the OHF works in conjunction with the RKSC, which is the Rare Kidney Stone Consortium, to triage patients to us if they contact them. Once the patients contact us at the Mayo Clinic, we will ensure eligibility. You have the ability to, if you're seeing us in person, you can sign a paper consent. We have the ability for you to sign an electronic consent. And then every year we just have you fill out a release of information so that we can request medical records from your doctor. It's really important that we keep the registry up to date so we can keep that complete picture available. And it's, sorry, my watch went off. And so we try to make the burden as less on you as possible to be able to continue to participate. Your data is kept secure. You're given a randomized 3-digit code so that nobody but the staff who works here knows who you are. Nothing is released that is able to be connected back to you. So that way your confidentiality is protected, but it does allow us to kind of look and see what the entire disease progression is. And it's important to participate because without you, we don't have those data points. We won't learn about what the disease looks like, and we won't learn, what kind of treatment should we be looking for, what's important to you. So I just want to say, thank you for your time. And if you have any questions, please don't hesitate to reach out to OHF and they will get you in contact with us at the Mayo Clinic.
Wow. Carly, that was a fantastic presentation. Quick and sweet and simple, and that's how we like it. It is really easy, folks. As Carly said, this is 100% confidential, your information secure, but what you can do with your information is actually help get drugs approved. And FDA and the EMA heavily used this registry to say, oh, it's okay, we have enough data and understand the patient journey. And that's how drugs were able to get approved. And we hope to see another drug approval in our near future. So I do want to remind every member of the audience, there is a comment section. If you would like to ask any questions, please do so. Julie's on standby in our back room, waiting for your questions. But we did actually get 2 questions in, so I'll turn it to Dr. Liskey.
Yep, thanks, Carly. We have one here. Says, does each person in my family that have PH need to sign a consent form?
Yes, so everybody who participates in the registry has to sign a consent form. If it is a minor participant, we would have the parent or guardian or legally authorized representative sign the consent form, but it is very important for every single member of the family to participate in the registry because we do see a lot of variability in families of how the disease affects people.
Gotcha. Here's a second question. It says, I live in Brazil. Can I join? Are patients in South and Central America needed for the registry?
Yes, please. We will take information from all around the world. It is an international registry. We are happy to work with translation services. We have a lot of great resources to be able to translate medical records, and we're happy to work with anyone, anywhere in the world.
Great.
Wow, Carly, we can't thank you enough. And if you do have any more questions, Carly will be hanging around and she'll be part of our panelists. So please continue to ask your questions and Carly will be on standby. All right, everyone, it's that time again. Polling time. Get your devices ready. Okay, so we have 4 polling questions and we will start in just a minute. So we're loading those polling questions so you can see about the registry. And this is going to be really exciting and just some information so we can get a better idea. Before this live stream, were you aware of how important it was to be part of a registry? This is a simple yes or no. And it's okay to not know information, but we're just curious. How many people knew the importance of a registry? All right.
Like I said, pretty even split here. So it's a good thing that we're talking about this.
Yeah, it really is. We're starting to see those numbers go from 50%, and now, John, we're actually seeing it lean a little bit heavier at that 56 to 40%. So really interesting. So great, guys. So the majority of people knew it was how important. We'll go to the next question. All right. So looking at question 2, are you enrolled in a primary hyperoxaluria registry? A, yes, the OHF Mayo Clinic Primary Hyperoxaluria Registry. B, Oxal Europe. C, you're unsure. D, other. And E, no. All right, so this is pretty interesting as well. Yes. Starting to see it roll in.
So far, even between Oxal Europe and OHF registries, and then a few no's down there.
That's great. So I'd say, based on this, Dr. Liskey, we're seeing a pretty even split between the OHF Mayo Clinic Primary Hyperoxaluria Registry and the Oxal Europe, which is amazing. Doesn't matter where your data is, as long as it is entered into a registry, that's the most important thing, because we can even compare data through different registries. And OHF works closely with the consortium through Oxal Europe, and so we're really seeing partner activities, which we hope to expand.
I see quite a few no's there just signed up, so more work to be done for sure.
For sure. Okay, next question. Would you like to receive information to join the OHF Primary Hyperoxaluria Registry? Yes, no, or unsure. And this could also be just general information. OHF and the registry, we put out information about what the heck's going on with your information. What are we doing with it? And so this is kind of cool. We send out patient reports, and say you have a question as a patient, we can query the registry and hopefully pull out that information for you. So these are all opportunities.
So far, most said yes, 86%.
Fantastic. And we'll move right along. So this is the last question of this session. And if you or someone you know suffers from enteric hyperoxaluria, would you like to learn more about being part of an OHF enteric hyperoxaluria registry? So we're seeing some questions, and this is sort of contingent on what we saw earlier. And most of the people I think are on the call are basically with primary today, which is fine. So we're seeing a lot of D does not apply.
Correct. So,
okay, so moving right along. Let's close out this session, and we're going to turn it over to Dr. Juan Calle, who's the medical director of the Kidney Stone Clinic at Cleveland Clinic. And he's going to talk to us a little bit today about access to care, right? Who is on my team? So Dr. Calle, I'll leave it to you.
Good morning, Kim and Dr. Blisky too. Thank you so much for inviting me. This is actually a very, very nice experience. It's so humbling as well and very encouraging to see everyone on the same page. So I can't see my slides here right now. Oh, there we go. Can you see them too?
They were just on our screen, and now they look like they're back, Dr. Calle. Take it away.
Okay.
Hopefully you can see it.
I am seeing them, but I cannot advance right now.
So we've just advanced to team.
Okay. All right. Well, so we'll go ahead and do it like this. I guess I'm gonna have to apologize, like David too, because some of these things they just come and they change, and I can see that because of the formatting as well, there is a little bit of a difference. I can tell you in the meantime that we are just a little bit behind Rochester, Minnesota, in the sense that we're gonna get snow later today as well. So it's not really that much. So anyway, so I just wanted to start showing you Cleveland, where I currently live. I endured the winters in Minnesota too. And I wanted to start with the team approach. And if there is anyone by any chance that knows anything about Cleveland and how things work here, these three teams are just big part of what everything is about Cleveland. Everyone is so excited and into it. And it just brings, I just wanted to bring that up because every time that we hear about a team, we may start thinking about teams like the Cleveland Browns, the Cavaliers, or the Guardians. But if you go to the next one, there are a plethora or many different types of teams anyways as well. If you go to the next one.
Next slide.
Okay, so I just want to show that different teams have different approaches. The main thing about this is that it depends what you focus on. In my case, I'm not that much of a big sports fan, but I do love the Cleveland Orchestra and the music here as well, a different team again. And as you can see, just like what we're going to talk about in our case, the different approach and everything that is in mind is for one goal, usually when you are part of a team. If you can go to the next one, please. All right. So I wanted to bring up these definitions that I found online when I was preparing for this part of the talk. Again, a team is a group of individuals. The interesting thing that I found here was that they described it as human and non-human as well, working together to achieve their goal. As defined by a professor in the Kellogg School of Management in Chicago, a team is a group of people who are independent with respect to information, resources, knowledge, and skills, and who seek to combine their efforts to achieve a common goal. I think that it went to the next one now. So then, again, the whole thing is talking about the fact that everything has to be focused on one goal. In this case, the goal is trying to help you through your journey in the different approaches that you have for this type of disease, which again, when I start talking here about who's on my team, we actually start with the start of the team. I like to start with the start of the team. And when I say that you are the start of the team, I don't mean only you as a patient. I mean you with all your surroundings. Like they say, it takes a village. The village here is your family, your friends, your close people. And obviously, that will include the team that is actually participating. And that includes us in that part of the team. But our team is actually quite big as well. We have a myriad of different people trying to work together with you. And as you can see here in this little slide is a cartoon. There are going to be people of all areas in medical care that will be involved in your care and trying to help you to reach that goal. The goal here again is having a good quality of life, being healthy, and overcoming some of the obstacles and some of the problems that we will definitely encounter during this journey, which is a long one. It's a hard one sometimes, but obviously, again, the goal is the same one, and is keeping you in the center of everything else. So now we started talking about the star of the team, which again I think is you and your family, loved ones, and friends. But like any other team that we were talking about, whether it was a sports team, a management team, an orchestra, for example, there's gotta be somebody who kind of directs things. The way that I think of this, usually the first access to all of this, the first access is usually just like David was talking about before. It may actually be a pediatrician, your pediatrician, or if you are actually diagnosed a little bit later in life, that may actually be your family medicine doctor or your internist, who are usually your primary care providers or physicians as well. Sometimes people actually have physician's assistants or nurse practitioners, but those are the people that usually end up being kind of the coordinators, and they work sort of like the orchestra directors or the manager of the team, sometimes even the coach, and they are very important. And I think that that's key to have a very good relationship with them as well. Who else may be involved? Unfortunately, many times you end up, one of the most common presentations again is a passage of a stone or multiple stones. So then you may end up being cared for at the emergency department. And the emergency department will probably have a team as well, but usually the one that runs that show, just to say it in that way, it's usually the emergency department physician or physician's assistant, nurse practitioner at that point as well. As you are going to see throughout this little talk, there are going to be a lot of people involved in your care, and you guys all probably are already aware and very familiar with that too. Then when things actually, and just like again, I want to reinforce the points that David was making as well. The kidney doctor, whether it's a nephrologist or the medicine kidney doctor, which is what I am, and the urologist or the surgical kidney doctor may be very involved in your case as well. If you're actually having a lot of kidney stones and they become symptomatic, if you're passing a lot of them, you may end up seeing the urologist very frequently, unfortunately, and that's obviously one of the things that we want to prevent, especially with the new medications that we have on board. And the nephrologist, or us, the kidney doctors, we focus a little bit more from the medicine part, especially if the kidney function, unfortunately, sometimes may be affected too. And that's when we play a key role. And we become sort of like, again, for those who are not in the States, we call it like the quarterback. If you are in Europe, you will be a little bit more familiar with soccer or football. That'll be the captain of the team, and that person is actually going to be, or us, we're going to be crucial as well to coordinate a lot of the care that you will need. Who else may be? The nutritionist or dietitian. Sometimes the diet, just even increasing the fluid intake, may actually be very helpful to have somebody like a nutritionist or a dietitian. They may help you out to find out some of the foods that sometimes, I mean, it may be a little bit controversial, especially for primary hyperoxaluria. But if the kidney function is affected, that may actually be something that they may help out, because the diet sometimes, unfortunately, needs to be watched very closely, and some things may actually end up being a little bit more restricted, trying to keep all of your numbers and your levels in your blood at a target that is significantly better for you and for your outcomes in the future. Dr. Sass, David, he also talked about the genetics, and as we saw, that may play a big role, especially now, and in the future, it may be crucial as well. So they're definitely part of the team and a very valuable part of the team as well. Something that I found, you can probably tell by my accent by now, that I'm not from here, something that I found extremely helpful here in the States when I moved, it was the help of the social worker. I heard that somebody was talking from Brazil and from Colombia. We didn't have access to a lot of help from social workers when I was back there. But if we can get somebody involved that may help you out navigate all of these issues that you will have from the socioeconomic part and trying to get medications approved, trying to go to different places to get your care, a social worker may actually be very valuable in your team as well. Now, unfortunately, because primary hyperoxaluria can end up affecting so many other organs, which is what we call a systemic disease. And not just like when people have kidney disease, sometimes we actually end up getting patients who have a lot of different organs or systems involved. We know that primary hyperoxaluria, because of the excess of oxalate, may end up affecting many other organs or systems. There have been people, or there are people who are actually diagnosed by different physicians or different specialties. Some of them, for example, the ophthalmologist, when they go and get their eyes checked, they may see some deposits or some changes in the eyes, in the back of the eyes, which is called the retina. The cardiologist, sometimes that unfortunately the excess oxalate may end up affecting the electricity of the heart, and they may need to end up being cared by a cardiologist as well. The orthopedic doctors, because again, some deposits of the oxalate may affect the bones, the ligaments, some of the joints. The neurologist, the same thing as well, because it may end up affecting the nerves. Some other ones like some manifestations in the skin. Sometimes the dermatologist may end up helping as well. So as you can see, there is a very wide manifestations of these diseases that may actually make us rely and have all of these other specialties as well on board for your management. Now, unfortunately, when the disease is very advanced, and depending on what stage you are actually diagnosed, some people may actually end up requiring a transplant team. Depending on where you are, the access to the new medications that you may have, the transplant team may involve not only the kidneys, but it may potentially even involve the liver team as well. So it's, again, a big part of a team, which we will need to coordinate with all of them, and we would like to be as involved and have everyone on the same page, which once again is your health and your quality of life. But that includes all of these themes that we're talking about. And ultimately, if you require more surgery, not only for the kidney stones, but in this case, for example, because of the transplant necessity, so that may include the anesthesia team, the surgical team, everyone who is surrounding the event at that moment, that may be part of your team as well. Now, because as we saw, many patients actually get diagnosed very early in life, there are some child life specialists who deal with these kind of very hard diseases that are diagnosed at a very early age, which that takes a big toll on the family and everyone else. And these child life specialists may actually help through the navigation together with the social worker and all of the other members of the team, as we talked about. And ultimately, I think that this is where I would do a little bit of advertisement for the OHF and different groups out there. It's very good to feel that you're not alone, and definitely you're not alone. You have all of us on board as well. But definitely, when you have somebody who has been going through something similar, it's extremely life-changing. I like to usually bring up my own experiences, and one of the reasons why I became a nephrologist or a kidney doctor is because my best friend back in Colombia, he had a different genetic disease, but he ended up requiring a transplant. He was on dialysis, and that obviously changed my life, but I saw how much support he could actually get from different people who had a similar disease like he had, and I would encourage you to do that as well. There are some people, I mean, obviously, every time that you talk to somebody who can relate to what you're going through, it's very rewarding too, and you can actually end up helping them. And just like they were talking about before, I think it was Kim, the one who was mentioning about the registries, giving your information that will actually encourage and it will help the field for us to learn and be able to help you and other people in the future as well. So this is just a little bit going around, just making or showing that there are many different types of the cogwheel that we have to coordinate. There is research, there is teamwork, there is vision, there is strategy, different connections that you have, and ultimately what we want to have is the goal that I had already mentioned for you to have a very good outcome and the best quality of life. And with that, I think I will end. Okay.
Great.
Take it. Dr. Calle, thank you so much. That was an incredible overview, and it really does take a whole village to have the team that needs to be around our patients. It's a complicated disease, folks, and we understand that, and it's important for you to understand to get the best healthcare management. And as Dr. Calle elaborated, we're working, and Dr. Sass, we're working very hard, and we'll be releasing some clinical care guidelines in the near future. So we hope to see improved patient care.
We do.
So let's get right to our polling, and we'll hold questions for Dr. Calle, and we'll do that in the more joint session. So we're going to go to our polling and get out your devices. And this is an easy one. There's only one question, but who is part of your care team? Select all that apply. So take your time on this. I know there's a lot of people, and we might not have everyone listed. Select all that apply.
So far we've had everyone picked at least once. That's good.
Yeah, so we're seeing a lot of patients. Their number one, Dr. Liskey, looks like they're nephrologist.
Correct, which, kidney disease is a big part of this, so that makes a lot of sense to me.
Wonderful. Okay, so thank you everyone for participating in the polling. We're going to head to our next speaker, and Dr. Barbara Cellini is coming to you live from University of Perugia, all the way from Italy. And we would like to welcome her, and she's going to talk about the latest from the lab, how research unlocks the answers to a cure. So Dr. Cellini, I'll pass it to you.
Thank you. Thank you for, can you hear me?
We can.
Yes. Okay, so thank you. I'm really honored to meet the PH patients community today. And as Kim said, my role will be to bring you on another side of PH, that is research. So let's start. By giving you an overview of what research is doing. So research project could be considered like they usually start with unsolved questions, and unsolved questions can be considered like closed door. So researchers perform experiments and hopefully they find the answers, and answers are like keys able to open the door. And when you open the door, hopefully you found ideas to develop new drugs. So today I will try to give you an overview, giving you three main questions on pH and how the answers have paved the way for new drugs. Well, as you know, PHs are diseases characterized by an increased endogenous production of oxalate that leads to the formation of stones at kidney level. The precursor of oxalate is glyoxylate in the liver. Well, so let's consider the metabolism of glyoxylate and oxalate in the liver like a system of pipes. And here you see glyoxylate that is converted to oxalate by LDH. So what is the source of glyoxylate and why it is increased in pH? Glyoxylate can come from vegetables through glycolate that is converted to glyoxylate by GO. But in the liver, we have an enzyme, AGT, that detoxifies glyoxylate to glycine. Unfortunately, in PH1 patients, there is a deficit of AGT, so glyoxylate builds up and is converted to oxalate by LDH. Glyoxylate can be also detoxified to glycolate by GRHPR, which is the enzyme defective in PH2, because again, if the enzyme is not present, glyoxylate builds up and is converted to oxalate by LDH. Glyoxylate can be also formed from meat-containing food, which have hydroxyproline converted to HOG by high PDH, and HOG can be converted to glyoxylate by HOGA1. It is known that mutations in HOGA1 cause PH3, but in this case we have a problem because HOGA1 produces glyoxylates. So it is still not completely clear why the deficit of HOGA1 in PH3 patients leads to increased oxalate production. So starting from the finding that the deficit of these three enzymes causes the buildup of glyoxylate, the idea came to try to, one of the ideas carried out at research level is to try to replace the enzyme. And this has been attempted, at least until now, only for AGT. So before to explain how this is performed, let's briefly remember how a protein is produced. The process starts from DNA, which is translated into an mRNA, which is then transduced into a protein, which plays a function. So as I said, different strategies have been attempted at the DNA level with gene therapy, at the mRNA level using liposomes, and even at protein level using nanoparticles. Moreover, many groups in the world have found that pathogenic variants associated with PH1 usually produce unstable protein. So the protein is there, but it is too unstable to perform its function. So different strategies are currently ongoing to try to stabilize these unstable variants. Among them, the vitamin B6. Vitamin B6 is a treatment, a well-known treatment for responsive PH1 patients, and my group and others have found that vitamin B6 actually stabilizes unstable variants. Moreover, my group has also recently identified a compound able to stabilize some of these variants, and others are working on molecules able to bring AGT to the correct compartment, because it is known that some variants are imported in the wrong compartments. Many of these projects have been granted by the support of the OHF. Well, the second important questions related to pH is, where does liver oxalate come from? And if we look to the scheme I just showed you, you can clearly see that there are three enzymes involved in the production of oxalate. They are GO, high PDH, and LDH. So if, based on these findings, the idea came out of blocking liver glyoxylate production and oxalate production by blocking these enzymes. Again, these can be performed using different strategies. The first one is at DNA level, using the CRISPR-Cas9 technology. By Cas9, you can cleave the DNA, and so protein production is blocked. A second approach is the use of the silencing RNA technology. Silencing RNA are small RNA molecules able to target the DNA and to destroy it. So again, protein production is blocked. Another strategy is at protein level, using protein inhibitors. Protein inhibitors are small molecules that bind a target protein and switch off its function. The first and the last options I presented you are still at the preclinical level. But the second one, the silencing RNA, is the approach that is at the basis of the two drugs, lumasiran and nedosiran, which are currently an option, a very good option for PH patients. Well, very quickly, the last question is the involvement of other organs, in particular the intestine, because it has been found that dietary oxalate is also important because it can contribute to urinary oxalate excretion. And based on this finding, it has been the idea came to try to metabolize dietary oxalate in the intestine in order to reduce the burden of oxalate in PH patients and also in patients affected by enteric hyperoxaluria. So based on this idea, different drugs are currently in clinical testing. One of those is Oxabac, which is a probiotic, while Nefure and Reloxaliase are two oxalate degrading enzymes. So today, I hope I tried to explain to you, to give an overview of the therapeutic strategies currently in the pipeline for PH at research level. So how all of this has made possible and what we need in order to bring all this strategy to occur. First, we need support. As I mentioned before, the OHF Foundation has greatly supported many of the projects I presented you today, including some of my group. And this has been crucial in order to have a deeper knowledge of the disease. And the deeper knowledge of the disease is the basis for the development of new drugs. In addition, the foundation has also funded mobility program, and I benefit from one of this. And these mobility programs have the effect of bringing together the research community and open the horizons so that you can cross and mix different approaches. Second, we need people. This is a picture representing my group, some people of my group in Perugia having the correct support allowed me and other people to involve other people, in particular young people, in the PH community. So now we have all these people involved, and that's a very good point for research on PH. And finally, we need patient engagement. It is well known that in rare disease, research should be pushed by patients. Patients play a very important role on research, not only at clinical level, but also at preclinical level, because they can suggest us the right questions. So please continue to be engaged. And so thanks again. I will be happy to answer all your questions. And if you are curious about the work of our group, follow us on Twitter. Thank you.
Well, Dr. Cellini, that was just incredible. And we will follow you on Twitter. Absolutely. Your lab is
Thanks.
One that is very impressive. So Dr. Cellini, and just to the audience, go ahead, post those questions in the comment section so that we can start answering them. But we did have a question, so I'll turn it to John.
Yeah, thanks for that great talk. So we have a question here. Why is vitamin B6 only effective for some pH-associated mutations?
Yeah, that's one of the main questions. Thanks to the support my group tried to answer. Actually, we found that vitamin B6, there is a kind of bottleneck. So vitamin B6 is only effective for those mutations that destabilize AGT. So if you have a destabilized form of AGT, vitamin B6 behaves like a lift that increases the stability of your variant so that the performance, let's say, of your protein can be pushed near to the normal so that your urinary oxalate level go down.
Great. And reminder, we do have a group session as well if people have additional questions for Dr. Cellini.
Yeah, thank you, Dr. Cellini. We'll see you in a little bit. Hang on.
Thank you.
Thanks.
Okay, back to the audience. So we do have some additional polling questions. Get your mobile devices or laptops and iPads, and we'll start doing our polling. So prior to this live stream, did you know how important research is to find treatments and a cure for hyperoxaluria? So it looks like numbers are coming in, and the first reaction is, yes, we did, which is great. So let's see, it could be a unanimous.
Yeah, so far it's staying at 100.
Yeah, this is really great. All right, so we'll move right along to the next question. Prior to this program, were you aware of the OHF's role in funding global research to develop treatments and ultimately a cure? So we're seeing the polls come in.
A little more mixed, 60-40 yes, no.
Okay. So I think it's important. We also want to say OHF has been supporting research actually since 1997. And I believe we've already hit the $40 or $50 million mark, and that's been matched about 10 times over, which is really interesting. So about half the people, Dr. Liskey, is new, and some did not. So it's a 50-50 split.
Yep.
All right, and our last question of the polling session for this latest from the lab is, do you feel it's important that OHF continues to train young scientists and doctors? How do we feel about this as a community?
So far, yes, all of them.
Yeah, I'm glad you believe what we believe, and OHF is dedicated to training young scientists and doctors, and we provide a number of travel grants, and Dr. Cellini probably can tell you about that later in our session, as well as career development grants. So we're partnering with a lot of different people. Well, that concludes our polling for this session. We're a little bit behind schedule, but not too bad. And we want to thank Dr. Yaacov Frishberg, who is joining us late in the evening from Israel. And he will be speaking to us about accelerating access to treatments and clinical trials. Dr. Frishberg, I'll let you take it away.
Yep. Hi, good morning, good evening, everybody. I'm really thrilled and very delighted to be here tonight. I mean, is this the right size of the slide? Hello? Anyways, so my job is, okay. So my job is to talk about access to treatment, and I'm going to give you some kind of a background, and then we'll try to see what can be done in order to increase accessibility to diagnosis and to treatment. So about 2 years ago, a group of physicians, scientists, representatives of the industry and the FDA convened together and published in CJSON a paper on endpoints of clinical trials in primary hyperoxaluria. This was accompanied by an editorial which looked at a different perspective, at the patient and the caregiver perspective. And this is very important. And what they looked at, they actually focused on various aspects of disease burden. Oh my goodness. So basically, they analyzed the patient survey, and as I said before, the patient survey actually focused on quality of life and disease burden. Altogether, there were 42 respondents, 17 patients, and 25 parents or caregivers. Among the patients, there were patients with all three types of primary hyperoxaluria, and at all age groups, about 50% of all patients were under the age of 17. And also with all stages of the disease, there were dialysis patients and there were patients post-transplant. Can we switch the slide? Next slide, please. Okay, so the first aspect was drinking water, and they commented that the amount of water required is burdensome and overwhelming. It may interrupt in school and work and may cause loss of sleep. And they gave an example of a 12-year-old boy who misses sleepovers, sleepaway camps, and overnight school trips. Next. Next slide, please. With respect to kidney stones, the kidney stone attacks are top concern. Procedures are traumatic physically and emotionally. And in addition, there is financial burden on the families who miss work. Next. The next issue that they dealt with was progression of kidney disease. There is obviously a lot of anxiety associated with the potential for end-stage kidney disease and for intensive hemodialysis, which oftentimes will entail 6 weekly sessions of hemodialysis. And there is certainly the fear of organ transplantation. In many cases, it's going to be a combination of liver and kidney transplantation. Next. And as far as the psychological effect of living with unknown future, there is the fear and the stress of not knowing when a painful kidney stone might occur, the dynamics between family members, especially in families where there is more than one family member with the disease, and when the severity of the disease varies among family members. And again, there is medical and financial burden from lost work. They concluded that we would be willing to take more risks for better quality of life. In other words, they would be willing, given the severity of the disease and the outcome of the disease, they would be willing to take more risk. In other words, they would be willing to enroll in clinical trials, hoping to find a better solution to primary hyperoxaluria. Next, please. I'm based in Jerusalem, in Israel. And about a few years ago, I was asked to give a talk about primary hyperoxaluria in the Middle East. Unfortunately, there is no formal registry in the Middle East for primary hyperoxaluria. And what I decided to do is to use the West Bank as a model. In other words, the West Bank is about 15 minutes drive from where I live and where I practice. And what I did was I focused on the central part and the southern part of the West Bank. And I called a friend and a colleague, a pediatric nephrologist from East Jerusalem. And we actually did a registry of the patients that we were treated at the time, which is probably a fair representation of patients who live in the central and southern part of the West Bank. Next. So altogether, we jumped one slide. The previous one. Another one. Okay, so one slide is missing anyway. Overall, there were 29 patients from 23 families. And if you, they all live in the central and southern part of the West Bank, a total population of less than 1 million people, 900,000 people. And so the overall prevalence was calculated to be 32 per million. 32 per million is about 10 to 30-fold above what's quoted in the literature for Europe and the United States. And if you take this estimate of 32 per million, you would expect that 91 patients in the West Bank, in a population of 2.5, should have PH1. And I can tell you this is certainly an underestimation, because number one, patients with mild phenotype are not diagnosed. There was incomplete screening of asymptomatic siblings. And unfortunately and sadly, I can say that there may be young infants who may succumb to PH1 undiagnosed. So probably we're talking about much more than 32 per million. I can tell you that we don't take care of, but we diagnose between 8 to 10 new patients from the West Bank and Gaza every year. Next slide, please. So Mrs. N is a mother of 3 kids with PH1 between the ages of 22 months to 11 years. In addition, she had 3 asymptomatic offspring, and she lives in the West Bank. When I asked her what's the most worrisome aspect of the disease, she said, the only thing that bothers me is what if they progress to end-stage kidney disease, because there are no options for liver or kidney transplantation in the West Bank. I should clarify that they live under the Palestinian jurisdiction and they are covered by the Palestinian medical insurance, which does not allow many of the procedures, and some of the treatments are not available. So next slide. So the question was, what needs to be done? The main reason that the prevalence is so high is probably for two good reasons. One of them is because there is high rate of consanguinity, and number two is because they have large families. If you have large families of recessively inherited disease, you're going to have more and more carriers, and over the years you're going to have more affected individuals. So, and we don't have a founder mutation. It's not that everybody carries the same mutation, but rather they have like private mutations in each village. So number one, we should increase awareness, which we should try to educate health professionals, but we should try to engage religious and opinion leaders from within the community and talk about consanguinity, and also to try and implement a targeting screening of premarital or prenatal diagnosis. Next. We should also try to enroll those patients in clinical studies, and I managed to enroll the 3 of them in a clinical trial, and they are doing well. And once a drug is approved by regulatory agencies, we should encourage companies to implement early access program and compassionate use program. At the end of the day, if you look at the figures which I shared with you, you'll probably appreciate that most PH1 patients who can benefit from the drugs live in resource-poor countries who cannot afford getting the drugs. So something else needs to be done. And the first step towards something else is the following slide. Okay, so this is a milestone, and this milestone is after work of a number of patient advocacy groups, as stated above. And this is a United Nations resolution of December 16, 2021, last year. And what they claim is that we should recognize the need to promote and protect the human rights of persons, including the estimated 300 million patients living with a rare disease worldwide. So for the first time, we have a UN resolution which actually deals with patients and their families. Next slide. So it's the first ever United Nations resolution to increase visibility of those patients. It was proposed by 3 members of the United Nations, by Brazil, Spain, and Qatar, and it was co-sponsored by 54 countries. But the question is, what does it entail? I mean, what are the principles of this United Nations resolution? Next slide. So the main principles were to foster inclusion and participation in society of people living with rare diseases and their families, to ensure universal and equitable access to quality health services without financial hardship, and to promote national strategies and actions. Next slide. Here you can see the difference between equity and equality. This girl can only grab a book from the shelf if you give her a taller stool rather than an equal stool to her counterpart. So we're talking about equity and not equality. And the equitable access is to diagnosis, to treatment, to health, to social care and opportunity. And they even managed to formulate a mechanism, next slide. And the mechanism is called universal health coverage. And universal health coverage should ensure that all people everywhere can access quality health services with financial protection and are not pushed into poverty. I think that the goal that this is going to be implemented everywhere is a bit up too ambitious, and the goal is that this should take care by 2030. But at least it's moving, because the WHO is in, and there are some national bodies that actually try to advance those principles, and it is optimistic. Next slide. And just in conclusion, last week at the ASN Kidney Week, I heard an outstanding talk by the Chief Scientific Officer of Moderna, And she actually defined a new avenue, and this is called mRNA Access Program. What they call is for researchers around the world who wish to use their platform, which help them to synthesize the vaccine for the COVID-19, to use the very same platform for whatever vaccines or whatever drugs which are based on mRNA they wish to do. So we are going to have access of researchers to a platform, and I hope this is going to be another avenue to help get drugs and health to all people around the world with PH and other rare diseases. Thank you very much for your attention. I'll be more than happy to attend any questions that you may have.
Well, thank you, Dr. Frishberg. That was an incredible overview. And we recognize here at the OHF how difficult it is for families to be suffering and not have access to care. We not only see it in resource-poor countries, but we also see it in places like the United States, Canada. We've had patients from Spain contact us. And so I think this access problem, right, Dr. Liske, you would agree, is a really big animal that we need to sort of reel in and figure out how best to tackle this as a community. And working with other patient advocacy groups, I think, might be a good way to proceed forward, and really understanding what's going on out there, what patients are experiencing. That's incredibly helpful. So I did see some questions come in, so I'll turn it to Dr. Liske.
Yeah, there's a good one here. It's because you talked about what the UN was doing, but this question says, what can I do to help make these drugs available in my country if they're not already available?
This is a good one. I mean, I don't know which country you're talking about and what's the system to approve new drugs, but I think that, I mean, each country has its own mechanism to approve new drugs, which usually, I mean, it takes into consideration the scientific and medical merits and also the price of the drug, and try to see and the size of the population that are going to benefit from it. I mean, I can just share with you the mechanism in Israel. I mean, in Israel, we have a national health law. So once a drug is approved, it's going to be free to everybody. But in order to get approved, the committee has to be convinced that this is, I mean, that there is a merit, a scientific merit, a medical merit, it's safe, and also that it's reasonable as far as the budget. So I think that based on the mechanism in this particular country, I mean, the one thing that they can do, they can try as a group of patients or patient advocacy group, or maybe with some help from the OHF or other organization, try to petition politicians or people that are in the process of approving new drugs.
Yeah, that's very important. Thanks for that insight.
Any other questions, Dr. Liske?
There's another one that's kind of related. It says, how can I know if a drug is close to being approved in my country?
What country are we talking about? I mean, I would assume that probably, I mean, if you Google your Ministry of Health, and probably they have a list of drugs that have been approved, you can find it. Otherwise, if you contact the company, I'm sure they will be more than happy to share with you the information whether a single drug has been approved in your country.
Yeah, that makes sense. Thanks.
Yeah, to that point, OHF is currently working with the regulatory NICE in the United Kingdom, and so we just got a little pushback from a drug that we're trying to get approved there, and we're also working with the Canadian authorities as well to try to get drugs approved in Canada. And I'll tell you, it's a long, tedious process, and we really rely on the patient voice along the way. And we need all patients to come together and unite. And if we stand together, we can be stronger. And, it's a rare disease, so the amount of voices we need from all over the globe is absolutely critical to move these drugs so that patients in different countries can actually get access to these drugs. And that really goes back to the patient voice. So we hope that you'll get more involved and join OHF to help us get these drugs approved. So thank you, Dr. Frishberg. I hope you'll stay on because you are part of our panel coming up. So we'll go back to the audience and let's look at our mobile devices and get ready for the next part of our polling questions. And prior to this live stream, did you understand what clinical trials were? And it's a yes or no answer. So prior to this live stream, did you understand what clinical trials were?
So far, 100% yes, which is great.
Yeah, so it looks like everyone understands clinical trials. So we'll move right along on question 2. Okay, waiting for question 2 to come up. So we're just taking 1 second. And here we go. Have you or someone you care for ever been enrolled in a clinical trial for hyperoxaluria? Wow, we're starting to see a lot of numbers come in. And they're shifting, so we have about 60% yes and 40% no.
That's a pretty good representation, really. Half or more have been in a study.
Yeah, so I would say in conclusion of this, about half of people are not enrolled and half are. And Dr. Liskey, this is limited today, but it would be interesting to dive deeper into this with the patients to figure out what countries are you even able to get into a clinical trial. So I think we have a little more digging to do as we move forward. So hopefully we could see the patients responding to these questions so we can gather more information and help get you into a clinical trial if you're not enrolled. Okay, so moving right along to question 3. Have you or a loved one received a specialized medication for primary hyperoxaluria, like an RNAi therapy? And you can also, D is, I do not have primary hyperoxaluria, so if this does not apply to you, that's okay. You can just check that box. So we're starting to see the results pour in.
Quite a few have, 80% right now have received a specialized medication, so that's excellent.
That's really great. Congratulations for all those people being on the forefront and entering clinical trials and hopefully receiving improved treatments. Right. So at the end of this, we're seeing about an 80-20 split, which is wonderful. Okay, moving forward with question 4. Do you live in a country where you cannot be part of a clinical trial for hyperoxaluria, cannot access certain medication? So the results are starting to come in.
So far, mostly no, which is also good.
Okay, so we probably have a lot of people, I would presume, from Europe and the United States and probably Canada online with us today. All right, so moving to our last and final question of this session. Are you interested in learning more about how to become an OHF advocate to help improve access to life-saving treatments worldwide? So immediate response, we're seeing a lot of yeses, which we hope to see as the answer. So let's see what we get.
A little bit no, unsure.
Okay. So we'll try to give some explanation, but we have about 50% of people would like to understand how to become a stronger advocate, which is wonderful. Okay, everyone. Well, that concludes our session for Dr. Frishberg. And now to a wonderful patient advocate and loving mom, Mrs. Kristi Ouimet, who is a strong person that really makes things happen. She's a mover and a shaker as a mom and as an advocate for her family. And she's going to talk about her family's journey. Welcome, Kristi. Take it away.
Hello.
Hi.
Thank you guys so much for including me on this. I've been fangirling over everybody that's on here so far. So it's been a wonderful experience for me. Let me see if I can get the slides. I'm not technical. I'm going to need someone to advance this slide. There we go. So in my family, I have 3 children, and 2 of my children were diagnosed with primary hyperoxaluria type 1. And as what has been spoken before about the diversity of how this can present within even your own family, we definitely experienced that. So my oldest child, Carswell, is currently 19 years old. When they were 3 years old, they started getting kidney stones. And that was one of the struggles we had back in 2006. Sometimes we'd take them to the hospital and we misdiagnosed. It was a cramp, or your child's just wanting attention. The children don't get kidney stones. There was a lot of struggles with things. And when we finally found a pediatric urologist who diagnosed and was able to remove the kidney stone through surgery, we were very fortunate to establish a good relationship with him, because anytime we go back to a hospital, we kept facing a lot of the struggles. And back then, we didn't have access to medical files through digital like we do now. I would carry a file with me, but he was very wonderful and gave us his personal contact number. So if we did go to a hospital somewhere, we would just give that number to the attending physician to be able to call to confirm what was going on. But we also finally got diagnosed when they were 6 years old. And my other son, my middle child, he's not a carrier. So we were fortunate with that, but we didn't quite understand what that meant. They just said it's kind of a wait and see, and we'll see how things go. If we're going to get a kidney stone, watch for the symptoms, and then we would treat it from there. I honestly didn't understand what PH1 exactly was. They told me back then, don't Google, because a lot of information online was not completely accurate. And it could be scary. So I just kind of winged it for a while. Then when I was pregnant with my 3rd child, we requested testing of him. And I was at my amniocentesis test. We had him tested, and it came back that he had PH1 as well. We made the assumption that he would present the same way that our oldest did, and we were very wrong. So even having all these specialists monitoring my pregnancy and delivery, at 28 days old, they wanted to do a baseline ultrasound, and they discovered that he had already had kidney stones. I'm going to stay on this slide, even though I'm explaining about my son, just because the way that it's the diversity in here and how it goes back and forth. So he ended up going into end-stage renal failure at 6 months old. Even with everybody watching him, they were surprised at how far he had advanced. So we had a new experience of 6 days a week dialysis, long commutes. And that's when I really reached out and got to know OHF and Kim and Julie very well. And we decided, since we were so confused about things and didn't know when this was going to happen to Carswell, neither did our doctors. So we decided to go public and just kind of put a face with what was going on. And we started sharing with the need for organ donation, but also making sure that we could give primary hyperoxaluria and OHF attached to all of our news articles and things that we had done to go public with things. We were fortunate that our community was very interested and did a series of news stories. And by the time my son got his transplant, he was 2 years old. He got a liver and kidney transplant. We were fortunate that they even allowed the videographer in the operating room. And so we were able to get medical schools and other places access to some of the data that was on there. And we just tried to use our story to educate everybody around us. When the story started going out there, people would Google the disease to find out what they've just been diagnosed or a loved one was diagnosed. And that's when we started receiving contacts from people from around the world. And using Facebook, social media was the best way to communicate, but it just floored me at how many people didn't have any access. The only information they can get was our news articles. So we were trying to find ways to get more accurate information out there. And again, partnering with OHF really helped establish that. With Carswell, one of the other big fears that we had was when is Carswell going to decline? And once my son was stable from his transplant, which he had a very difficult recovery, I became a bit frantic, a little obsessed with trying to find something. I didn't like being told, well, your child's not going to get referred to the hospital that knows about this disease until it's too late and they are on dialysis. That's our policy. And I said, well, your policy sucks. And was able to go forward and explain it by using the patient voice. That was something I realized had power. And it was something that I can prove because not only did I have documented things of my son, but I had this incredible care team who wanted to help and wanted to be a part of it. And having somebody actually listen was incredible. When we got to go to New York and talk to the FDA and speak with people with OHF and the pharmaceutical companies, and not only listening to our story, but to our children. And that was very powerful. And it kind of woke something up inside me that I realized all those years of feeling helpless, I could do something. And then that kind of translated to, so can other people. Unfortunately for us, we always seemed to be running short, just a little too far behind. And when Carswell started declining, we were hearing about these clinical trials, and some people were hemming and hawing about, do I want to be a part of these? I don't want to be the first patient to be involved in a clinical trial. What if there's side effects or something? And I'm over here jumping up and down, screaming, me, we need to get my child into this. And we finally were able to screen for one of the clinical trials, but Carswell had declined too much for that stage. So then we had to wait for the next one. All the while, they're passing kidney stones constantly, trying to deal with being in high school, trying to care for my other kids at home with things. And it was very exhausting and scary, but it just reinforced I wasn't going to stop. And we were able to screen again, and we thought we were going to get into the trial, but they denied us off of some technicality with our genetic report with my mutation. And it didn't make sense to me, but I realized it didn't matter. So that's when I got introduced and met Carly. And she became my go-to for so many things. And I think that's what the overall thing with the patient voice and access is care. There are people there that want to help and they offer their help. It's our responsibility to take that help. But I also take it as we need to then be the help for other people. We were able to get Carswell into another clinical trial, and things started. We were very excited at the hope of it, but Carswell kept declining. And before we were able to finish, we were told we're no longer eligible because their oxalate level had gotten too high and we had to start dialysis. We were actually on Capitol Hill talking to Congress about our story and how important it is to speed things along, because here for years we were trying to get there and we just missed it. And we found out later we were getting placebo. So didn't quite work. But our team of people really fought for us. And as Carswell started on dialysis, we were able to get compassion use of that medication. And it, within months, started working tremendously to where we were able to reduce the 6 days a week dialysis down to 3 days. If you want to move to the next slide, I'll explain a little bit more with Matthew. There's our little guy. Matthew, when he had gotten his transplant, then we had some stability for the most part. We still had G2 meds. He had to recover from a stroke. So we had a few other aspects that we had to deal with along the way while we were getting Carswell into the dialysis. Unfortunately, at his transplant, when he was 2, he had an adult liver and kidney donor, but his kidney had taken such a hit with the excessive amount of oxalate in his system that it was damaged at transplant. So we knew it wasn't going to last. It did last a few years. But as Carswell was on dialysis, Matthew ended up, his kidney went out and he had to go on dialysis. So I had both kids on dialysis at the same time, same hospital, same team, which was great. And then finally, as we were moving forward with things, both the kids got their transplants within 24 hours apart. And Carswell's the first patient that we were aware of in our area to get kidney-only transplant because their oxalate went from in the 80s down to below 5. And then after transplant, now it's they can't detect it. So we're still on the medication. They're still doing great. Unfortunately, due the way my kids tend to do things, they're both facing rejection, early stages of rejection, but that's something that has nothing to do with the disease, and we're just battling straight on. Every time we have a hiccup in things, we call it a plot twist, and it just makes our story a little more interesting. But we've documented things all along to make sure that we can show people how our story has progressed. Next slide, please. When our children were in dialysis, again, stuck in that room feeling helpless, we turned again to the social media, and we have a few support groups on our social Facebook page. And when COVID hit and was really struggling getting people access to care, I just continued to play operator and connect people. I would reach out to Mayo Clinic and ask Carly, what kind of patients do you need for what study? Because people in my social media group were asking, how do I get a study? So we kind of connected some of the people that could try to get access to those locations, even though COVID had come in. And then from there, I started establishing some pretty incredible relationships with some of the other patients. And one of them in particular was Govinda from Nepal. And he had just gotten married, and 2 months after his marriage, he went into kidney failure. Didn't know why, had to start dialysis. Months later, he ended up getting diagnosed with PH1, but in Nepal, you only do 2 days a week dialysis, and you can't get any help with any other medications or anything else that's out there. And then his wife, as a nurse, was trying to take care of him, but even the hospitals where she was working at were saying there's nothing we can do. He's not going to make it. And I told him, that's not good enough, and we'll fight for whatever we can do. When we realized there were struggles from other countries that we didn't really have access to, talk started a little bit more on, could we bring him here, and could we get him care here? And everything kind of fell into place. And we flew Govinda and Mira. We got them immigration access to come for humanitarian parole. And they have been living with us for 1.5 years now. And he's been receiving dialysis 4 days a week compared to the 2 he was. He's getting also the compassion use of the medication. And that mixed with the B6 is really incredible. My children didn't respond to B6, so we didn't have that option. But it's doing remarkable, and he's on his way of getting kidney only transplant as well. Excuse me while I hydrate. Since we've been able to help them, our story's been picked up by People Magazine and the Tamron Hall Show. Excuse me. You'd think I'd never talked before. And so what we've done is we've just using that opportunity and the platform to raise awareness and to see what we can do. Next slide. What we're trying to tell everybody to do is you work with your experts, you manage your care, you use your voice. I think people are intimidated talking to their doctors. And it doesn't have to be that way. You need to establish relationships with them. You need to be able to communicate and find out what's the best way to communicate. Is it email? Is it through the office voicemail? Anything like that. And make sure that they know you. Make sure that they know my children are completely different in how they respond. And I need to make sure that I have those connections. And most recently, we've learned it's not just pediatrics, but now changing to adult. And boy, has that been an eye-opening experience for us to not only try to encourage my oldest to use their voice and to explain things and to still have access and guide them, but now we have a whole new set of doctors that we need to educate. I think that there's a lot of people within these specialty fields that don't have the egos that people expect. They're incredible. All the people that have spoken today, everybody, they want to help people. And so it's important that we do that and we encourage people to use your voice and your story. Don't settle for sitting there. Next slide. A lot of this was already spoken with previous people, but make sure that when new people get introduced to our group page, a lot of people refer them to me because I'm like the mom of the group. And the first thing I try to ask is, what do you need? Where do you live? What is the status of your disease? Educate them on certain keywords of things that they're going to become second nature to. Creatinine, oxalate level, nephrologist, all those kind of keywords. And then depending on where they're at and what they need, if there's any way we can get medication to them before they decline, then that's great. If there's a struggle with insurance, we like to educate them on, would you like to see if the medication's that expensive, do you want to see how much it is for dialysis and transplants? Because I have those and it's a lot. And so it's just really important that you learn what advocating is, and you learn that sometimes people aren't going to do things for you, and you can't sit there and wait for someone else to do something. Literally, where there is a will, there is a way. And I've just become the point where if there is something out there, if there is a treatment out there, or something can happen to help somebody, then we're not going to stop until we get it to them. And if that means getting someone to another country or getting medication to that country, then that's what we're going to do. Every patient's story matters. Every patient's perspective matters. So it's up to us to really push that. And that's what I try to help encourage. Unfortunately, it's taken things like some of these larger publications to legitimize things or to validate stories. I don't care. We're going to use it, and we'll do whatever we can to make sure that every patient gets what they deserve. So that's it for me. I appreciate your time. And again, I'll take any questions as well if there's anything I could do to help.
Kristi, that was just incredible. And truly, you are a superhero. I mean, everything that you've gone through, and Kristi and I are basically on speed dial these days, and just traumatic events in our family life. One question before we jump to our panel, which you'll be on, and people can certainly ask questions. Remember, at the comment box right below that event page, you can ask whatever questions you like. And then we're going to switch to our after party with Zoom. So get ready for that. But Kristi, if I'm a new mom or a patient with this disease and I want to access the Facebook groups, how do we find you?
Basically, hyperoxaluria, once you're going to learn how to say these hard words and move forward, you just go to the search in there. We actually have two groups. A lot of us are in both the groups. And so usually when we post in both. Not all the times does it pop up. But if you just type up hyperoxaluria, there's two different ones in there. One of them says parents of patients with hyperoxaluria, and the other is primary hyperoxaluria caregivers and patients. So it's just a little play on words with either one of them. Click to join.
Great.
And one of us always tends to greet, ask a question, get involved. And that's one of the things that it really helps. And if it's somebody that needs follow-up, I always go and message them privately.
Well, that is just incredible, Kristi. And if anyone is looking for patient support groups, you can even PM us on Facebook, or however you want to get in contact with us, email us, and we'll certainly point you to as many Facebook groups as possible. There's plenty in Europe. And even if you're not native in English, there's translation now with Google Translate. So we just want you to connect and make sure you find the home that you feel most comfortable in. Well, I have to say that was just absolutely incredible. And we're now moving to our panel. So we see Dr. Cellini and Dr. Frishberg, and we are, I'll date myself, like the Brady Bunch right now, for those of you that are old enough to remember. But this is something that's familiar to us. This is our Zoom world, right? And in the after party, we're going to go right to a big Zoom thing. So there'll be another link under that event page that you just click on. And there's two links in case you can't get in. But we want to encourage you to partake in that, because that's going to be a closed session. So it's just with families and caregivers and patients. There'll be no outside people on it. And it's just for us to get to know you and understand what we're going through as a community. So this is really exciting for John and I, and lots of questions were rolling in. So John, I think you have a handle on a new question.
Yeah, well, at first there was a comment from Kristi's talk I thought I should share. It's from the Netherlands. It says, Kristi, your story is so familiar with ours. Thank you for sharing and caring about others. And I think we can all echo that. That was a great talk.
Oh.
Thank you for sharing.
Thank you.
And big hugs going out to the Netherlands. I know there's a lot of struggles there, and we hope that, there is no borders in rare diseases, folks. And we all have a heart, and we all have these kidneys in this group that tend to do some bad things to us. So make sure you're connecting with each other. And it could be, folks from the Middle East, it doesn't matter. We are all in this together. Okay, any other questions?
Yeah, here's one for Dr. Frishberg. It says, my child has an unknown form of PH. Do you think there will be a PH4 or PH5?
Maybe. I'm sure that there's a group of patients with hyperoxaluria, and they don't have any sign which is suggestive of enteric hyperoxaluria. And the question is whether they have another form of PH. I know that there are a number of groups around the world trying to identify PH 4, 5, 6, 7. I'm hopeful that one of us will find it, and it's going to serve the entire PH community. But for the time being, we do appreciate a group of patients with untyped PH.
Yeah, and I think just to add to that, thank you, Dr. Frishberg. I think it was Dr. David Sass saying, hey, if you were genetically screened through an outside company, is there value to actually going through a research protocol? And I'll do a little plug for Carly over here, but there is, right? So through research genetic testing, we can dive in, or the researchers can dive in and really see what's going on. And there's different mutations. 2010, Dr. Frishberg actually discovered PH3. So, and that came from patients that had an unknown type. And then in 2010, he was actually able to say, there's a subset of patients that all share this characteristic. And that's how we learn. So it's really important to think about that as you move forward.
Okay, so we have one here for Dr. Calle. It says, how do you maintain team communication in your stone clinic, even if someone roots for the Steelers?
Well, I guess there was somebody paying attention to my team's effort. Well, it's always hard. I mean, and I can relate so much to Kristi, and I'm sorry if I'm calling you by your first name. Because again, as I said, my personal experience actually started from my best friend, and I can relate to this very much. It takes a lot from you as well. I think, again, Kristi's story just go right on point, because you have to be the biggest advocate for yourself. Many times, for whatever reason, sometimes it's because we don't know, because you are at a center that may not have that much experience. I forgot to mention that that's something that we have been working together as well with the OHF, trying to come up with these centers of excellence, because it's very hard to know about these diseases. And we, all of us, are learning day to day. The experience that I've had with the foundation, every time that we have a meeting, I learn something new. So coordinating, you're probably going to have the quarterback, the captain of the team, you're going to have the team manager, and it's a coordination. Sometimes there's going to be one day that one is having a very good day and is going to help you. The next day may be another one. So sometimes you may get information from these support groups, something that you didn't know before, and that person has already gone through those hurdles as well, and they may tell you, well, instead of calling Dr. Liski, call Dr. Sass, or call Kim, or call me, or Yaacov. Trying to get everyone on board sometimes is difficult, but I think it's just pushing through it and being very enthusiastic about it, and knowing that at the end of the day is that goal, is just trying to keep everyone together. But I do believe that there are some quarterbacks or captains that may coordinate a lot and may make it a little bit easier for you too.
That's good insight. So we have a question here for Carly. It says, will my name go into the registry for all to see?
It will not. It goes into our database so that way we know who you are, and we know when we ask for your medical records every year that we are putting it in the right spot. But it is, like I said, a coded number. So you're given a randomized coded number, and that is all that goes out to any researcher or pharmaceutical company that's utilizing the data. None of your private health information is ever released to them. It's only in my locked area.
Perfect. That's reassuring to know. So we had, let's see. So for Dr. Cellini, we didn't talk about this, I don't believe, but the OHF has Young Investigator Travel Awards. And the question is, how has that impacted your team there in Italy, having some of those, the availability to those awards?
Yeah, one of the people of my group was granted by this program, and it is great because the community is small, and creating connections between people working at different levels is truly an added value. Since this is a meeting for patients, I would like to let them know that when you see a new drug, usually there is a company, a private entity that develop a drug. That's normal because in an academic setting, this would be not possible. However, one should take into account that always any drugs comes from basic science information. And basic science information should be fueled by the support I mentioned before and by people connecting with each other. Just for example, I was only working with protein at the beginning, and then I met people working with cells. So people from my group were sent into different labs trying to work also with cells. And these cross connections are crucial in research because different perspectives gives better news and brings you more faster to the end, to your goal.
Yeah, that's good insight.
Yeah.
So as a follow-up question here was, you talked about non-RNAi medications in your talk that are under research. Can you tell us just a little bit more about what those are?
Sorry, can you repeat
It
which
was
kind?
about non-RNAi medications. So we know that lumasiran is an RNA inhibitor, but are there others? You mentioned there are others, and I guess they want to know a little bit what that means.
Yes, all the others, except for intestine-directed drugs, were not tested in humans. That's the side of the story I'm more expert, actually, and that's the preclinical level. This means because before testing in humans, any strategy, any drug should be tested in model systems like cells, animals, and so on. Only when a strategy is known to be effective and non-toxic for human, it could be tested in human. And all of what I mentioned in my talk is tested at preclinical level, except for RNA silencing, like, for example, gene therapy. Gene therapy is an approach that for some rare diseases is still something that has been approved, but in PH at the moment has been only tested at preclinical level because one should be very careful that there are no side effects and no toxic effects in particular for humans. Or, small molecules, for example. That's a great field because, we have some biological drugs. Silencing RNA is a biological drug. This means that it is also very expensive. And so another strategy is to look for small molecules that could integrate, in particular for patients having mild form of the disease. And small molecules are cheaper, but again, they should be tested and developed.
Great.
And I want to underline again, if anyone has any question for me, please contact me. I will be more than happy to answer your question.
Wonderful. Well, I just want to say thank you to our panel. We couldn't have done this without you. You've been amazing. And we did get one final question, but I'm going to hold that question for Maya, who's up next. And I just want to say thank you to our panel. And again, some of our panelists will be on the Zoom after party. So a lot of the questions we didn't get to, we'll be able to answer there. But as we segue into Maya's presentation, I just want to say how amazing this group has been. And Maya is an OHF staff member. She's one of our research associates. And she's going to talk about the last question that we didn't get to ask is, you know, what could I be doing more of? And so I thought instead of answering that, Maya's going to give you a little bit of some things for Hyperoxaluria Awareness Week. And I'll turn that right over to Maya. Thanks, Maya.
Thank you. Good afternoon. It's just about afternoon where I am. My name is Maya, and I'm so excited to be here wearing my Hyperoxaluria blue with a quick update from the OHF. As we wrap up Awareness Week 2022, we've heard from our incredible advocates and amazing experts about how important it is to keep access at the forefront of our mission. To keep powering this fight to generate change for people everywhere living with hyperoxaluria, their families, and caregivers in the global community, the OHF is kicking off our end-of-year fundraising Access for All campaign from now through Giving Tuesday, the year's largest day of giving, and wrapping up on December 31st. But we cannot fight for these rights and for the future of the hyperoxaluria community without you. And your words really do say it best. These are some of the rights that you have voiced the importance of during Awareness Week 2022. You voiced the importance of education, one incredible family sharing the challenges of educating family and friends on their daughter's PH3 diagnosis. You shared the critical need for care, another family emphasizing limits in access to dialysis and transplantation. You voiced how a lack of awareness can make it impossible to access that critical rapid diagnosis. And you shared the importance of the right to treatment to make sure that amazing children and families all around the world have the chance that everyone deserves to enjoy being kids and growing up. As you have heard from the speakers today, the OHF is working to support future efforts in raising awareness and finding a cure, but we cannot do it without you in the fight with us. Join Team Treatment, Team Care, or Team Diagnosis today. Use your voice to share what access means to you and continue to make progress in these areas possible. Visit this link or scan this QR code to create a page and set a goal. Then share your story and join the fight to change the future of hyperoxaluria. It's that easy to do something today to change what tomorrow looks like for everyone with a hyperoxaluria diagnosis all around the world. We hope that you will join the amazing community members who have already taken part, and we look forward to some friendly competition for the prizes that are on offer. As you have seen this week, we cannot change the future of hyperoxaluria for everyone in this community without your voice. And speaking of the incredible community all around the world, we are going to head into a quick break shortly, but we hope that community members, families, patients, and caregivers will follow the link for the live after party and patient meetup kicking off very soon. Thank you again for your amazing participation in Awareness Week 2022, and back to the studio.
Maya, absolutely incredible. And I know certainly I'm going to join a team. So it's really exciting. You can find more information about it at hyperoxaluriaweek.ohf.org, where you access this amazing program. And we're just so incredible for our staff members who helped us get this together, to our speakers, to all of you who spent a Saturday morning or evening with us. And just to my co-host, Dr. Liskey, it's been a great time. Dr. Liskey will be joining us in our after party, and I hope you'll stay on. So all you have to do is go to the bottom of the link right below how you access this player and click on Zoom. Take a short bio break, and we'll see you in the after party. Thanks, everyone. Have a great day. See you in a few minutes.